Hi, my name is Amita Gupta, and I am the Chief of Infectious Diseases and the faculty co-chair of the Johns Hopkins India Institute. And it gives me great pleasure to greet you with my co-moderator, Debashri Lokande. And together, as part of the TB Summit, we will be discussing some new diagnostics and treatments, and to put in context some of the sobering statistics that we have identified during the COVID pandemic. So I will just start by saying a few words that I think we all are very familiar with, unfortunately, with the fact that the global TB targets are mostly off track, and that COVID has reversed years of TB progress. It's now estimated that 10 million individuals in 2020 were diagnosed with tuberculosis, and many of them went unreported. In fact, only 5.8 million of these individuals were reported to the healthcare system. So there was a large drop in notifications, and in particular in places such as India, Indonesia, and Philippines, this was particularly marked. For the first time in more than a decade, tuberculosis mortality has increased, and where we saw more deaths at 1.5 million people dying of TB. We also noted reductions in the number of people getting treatment access for drug-resistant TB. We also saw fewer people getting preventive treatment, with 21% receiving less treatment. And we noted that there was an increase in poverty and malnutrition, the very factors that are associated with increasing TB incidence. All in all, this compounded by less spending on important things like TB diagnosis, prevention, and treatment. In fact, less than half of what is necessary to combat TB was what we saw. And these here just show you very quickly for the first time, these increases in TB being detected and more people dying from TB. And when we look at these graphs, you just see again for India, where there was both an uptick in the mortality and decreased case notification without any increase in spending to combat TB. So we are going to need many steps urgently to address these sobering facts. We need to end the pandemic critical to the recovery of TB services. We need to invest in better data systems. We've learned from COVID that we have a fractured public health system globally, and India is not alone. We saw this everywhere, where we need to invest in real-time data systems, getting COVID numbers, getting TB numbers to be as accurate as possible so we can identify and target our resources. We need to improve case detection. And we need a lot of collaboration. We know by collaborating together, we can make things happen. And so you're going to hear from several of our speakers today who are going to talk to you about new tools and for diagnosis, new tools for treatment, which are really very exciting. But we have to remember, with this excitement, we need to ensure access and equity and delivery at the cheapest cost for the most people with the greatest equity. So I'm hoping you'll enjoy talks from Dr. Kelly Dooley, Manank Shah, and our very own TB survivors who will tell you their stories. And you will learn about some of the exciting studies that include, as I said, new diagnostics and new tools, as well as new treatment trials that are shortening the length of how long we have to take treatment. They're now safer. They're available all in pills and have, and we know we need them for a shorter amount of time. But again, we cannot transfer our research into practice until we have this made available for everyone. And it's really critical that we work on that side of things as well. So thank you for giving me the opportunity to speak to you today and to be your moderator.
Hello, I'm Ashna Ashish. I'm a public health professional, a lawyer, and an MDR TB survivor. I'm honored to be speaking here on this panel on TB treatment access and strategies. My presentation specifically looks at giving an overview of access to TB treatment in India. Just some context setting before we dive in. TB, though curable, remains one of India's severest health crises, killing over 1,200 Indians daily. The disease takes its most dangerous forms with delay in diagnosis, delay in and inaccessibility of treatment, increased suffering due to side effects, and mental health issues for the affected persons. The COVID-19 pandemic has only exacerbated these challenges. A quick look at treatment in the public sector versus TB treatment in the private sector. So in the public sector, TB treatment is free, but there are hidden costs associated. This could be the cost of travel from one's hometown to a treatment center. It could be associated with nutritional costs, the cost of supplements. The treatment is reliable, but not always so. It lacks patient support. The healthcare system focuses on numbers rather than quality of care. And there's minimal economic support in the form of the Nikshay Poshan Yojana with a meager 500 rupees per month. In the private sector, care is expensive and unreliable. It's not affordable for most and thus pushes them into debt. It offers little to no patient support. It lacks focus on management of side effects. And there's a suboptimal quality of care and a high dropout rate. Now, this is alarming because patient perceptions that the private sector provides better quality of care with more focus on the patient's well-being, but it is unaffordable for most. And given this perception, a significant majority of India's TB patients seek care in the private sector, despite the challenges of misdiagnosis, delayed diagnosis, and incorrect treatment. Now, the private-public amalgamation is a model with various benefits that the government has been exploring in a limited manner with its private sector partners. Now, the benefits are that the patients choose their healthcare provider. Patients have access to adherence and follow-ups in the private sector. Patients get access to new drugs and regimens. There's a better quality of care ensured, and it's more affordable than care outside this model. However, there are still drawbacks. This model is still limited within its reach. Costs, though lesser than before, are still unaffordable for some. On account of factors like delayed incentives and being overburdened, doctors may often be reluctant to engage with the system, and patient support still remains missing. But what we do know from our learnings from this model is that the interaction of the private and public sector in an organized way can help India in achieving its goal of TB elimination. Now, what has the impact of COVID been? So, an overview, we do know that the COVID-19 pandemic ended up having a huge impact on TB care, and this includes TB treatment as well. In fact, if the National Health Mission data estimates that there was a 45% decline in the number of patients who signed up for treatment in June 2020, which means that, and even stories we've heard where people have reached out to survivors against TB with queries confirm that there was an inability to access treatment in many forms. There was an inability to afford treatment, and there was a difficulty coping with side effects, given that most patients could not access their doctor or health workers. Let's have a more granular look at COVID's impact on TB care and treatment in particular. So in terms of diagnosis, we know the diagnostic centers were shut down in some places. There were delays in diagnosis with the CBNAT machines being diverted to COVID testing. And in treatment, we saw non-availability and decreased availability of drugs for both drug-sensitive and drug-resistant TB patients in both the public and private sector. In terms of support, with COVID-19, it was an all-hands-on-deck situation, and all health personnel, including health workers, were diverted. So there was a lack of provision of supportive supervision, monitoring, and support in the treatment process for TB patients as a result of everybody being focused on COVID. Again, the lack of transportation has restricted the ability to access health centers, particularly during lockdowns, where people without private means of conveyance had no way to reach their diagnostic centers or health centers. The lack of access to health services has also brought up the issue of management of adverse drug reactions and comorbidities, with many affected individuals struggling during the pandemic to do so. As a result of COVID-19, these challenges are bound to increase and impact a patient's ability to continue treatment. So what can we do about this? To begin with, we need to adapt existing delivery approaches to pandemic needs. This would include TB diagnosis through door-to-door testing and contact tracing. But more particularly in treatment, it would mean that if a patient can't reach treatment, then treatment needs to be made accessible by taking it to their doorstep. This needs to include side effect management and patient support, including mental health support, to deal with the issue of the stockouts. Every patient should be given a buffer stock of medication. So let's say about 2 to 3 months of medicine supplies in one go. What's also critical at this time is patient education. So leveraging remote support and communication for increasing patient awareness about TB, its treatment, its physical health and mental health side effects, and also establishing through digital means local networks that can address patient queries and provide them with some semblance of credible public health information that would help them to quite an extent not just self-manage wherever possible, but also be aware of when they need to seek care and how. Given how the pandemic has affected the economy, now it becomes more critical than ever to ensure robust socioeconomic support mechanisms, because a significant amount of people in the informal sector have lost their jobs. And if these people are affected by TB, they would need increased socioeconomic support. And the way to do this would be to increase the amount in the Nikshay Poshan Yojana and factoring in hidden costs of treatment and providing for those. Another thing that is critical is ensuring access to gender-responsive, high-quality TB care. Now, care is not limited to diagnosis or just treatment. It has to cater to the varying needs of different genders. It has to be provided with dignity, and it has to be provided stigma-free. That is crucial to ensuring good patient experiences and outcomes. Another key aspect is survivor involvement. So survivors need to be involved in this process of revamping access to TB care and treatment. They need to be involved in the design of a revised access policy and its implementation. And why this is critical is because they understand end user needs and challenges, and their inputs then become critical to framing policies in TB treatment that speak to these end user needs and meet these end user needs. Let us work together to make TB treatment and care equitable and accessible. Thank you.
Hello, I'm so pleased to be here with you today. I'm going to talk to you today about an overview of new tuberculosis treatments. My name is Kelly Dooley. I am a professor of medicine at Johns Hopkins University with appointments in infectious diseases and clinical pharmacology. Our objectives today, we'll talk briefly about the epidemiology of TB, including drug-resistant TB and the urgency of need for new treatments. We'll talk about some new treatment regimens proven to be effective, as well as new drugs for TB treatment. We will look together at the drug pipeline and the trials landscape for TB and highlight some important reasons for hope. So state of the state, I think many people at this conference are familiar with TB and its treatment, but I will just highlight that as of 2014, TB surpassed HIV as the #1 infectious killer worldwide, although we know that COVID has since surpassed TB. It remains a top 10 global cause of death, and our treatment for drug-sensitive TB still takes 6 months to complete. Multi-drug resistant TB, TB resistant to isoniazid and rifampin, is common. There were 465,000 incident cases in 2019, and MDR TB treatment is successful in only 59% of cases. Surely we can do better. For HIV at least, there are many different regimens on the shelf. Multiple fully active regimens, 1 pill once a day. Many are well tolerated, and now there are even long-acting injectables that patients can receive on a monthly basis for full control of their HIV. Can we do better with tuberculosis in the same way we have done well for patients living with HIV? So, well, there is some reason for hope. We now have a 4-month regimen for drug-sensitive TB as a result of this trial, which was Tuberculosis Trials Consortium 31, AIDS Clinical Trials Group A5349. In this trial, a rifapentine and moxifloxacin-based regimen was non-inferior to a standard of care regimen with isoniazid, rifampin, pyrazinamide, and ethambutol. In this trial, I should highlight that there were 34 clinical research sites in 13 countries and 4 continents, including 2 sites in India, so the results are highly generalizable globally. The trial design was, as you see here, people were randomized to 2 months to a standard 6-month regimen, to a 4-month regimen in which they received rifapentine, isoniazid, pyrazinamide, and ethambutol for 2 months, and then 2 months of rifapentine and isoniazid. And the third regimen, the one that turned out to be successful, had 2 months of rifapentine, isoniazid, pyrazinamide, and moxifloxacin, followed by 2 months of rifapentine, isoniazid, and moxifloxacin, as you see here. And so I will just show you the primary efficacy results that the rifapentine, moxifloxacin-based 4-month regimen met non-inferiority criteria for efficacy in all analyses. Even in subgroup analyses, patients who received this regimen had non-inferior efficacy compared to standard of care, including people with HIV. For drug-resistant tuberculosis, there is also reason for hope. Here, in this trial, among patients with extensively drug-resistant TB or hard-to-treat multi-drug-resistant TB, a regimen of 6 months of bedaquiline, pretomanid, and linezolid cured 90% of patients. This was a small trial with no control arm, and there was significant toxicity, specifically peripheral neuropathy and myelosuppression. Most of it was manageable and reversible. And so this led to registration of pretomanid as part of bedaquiline, pretomanid, linezolid in several countries. In terms of latent tuberculosis infection, if there are 2 or 3 billion people with latent TB in the world, could we possibly do better with very short treatment regimens so that we can cure patients of their latent TB and prevent TB in the first place? So you can see here, these treatment guidelines, this is for people with HIV in the United States, just came out last week, so these are hot off the presses. You will see that isoniazid preventive therapy now is listed as an alternative regimen, and that 1 HP, 1 month of daily isoniazid and rifapentine has now become a possibility for patients. Preferred regimens include 3 HP, so once weekly isoniazid and rifapentine, or 3 months of daily isoniazid and rifampin. I find this 1 HP regimen to be highly exciting as it is ultra short, and in people with HIV seem to be quite effective. So just showing you here the 3 drugs that I call second wave drugs. So we had a first wave of drug development in the 1950s to 1970s, and then a hiatus from TB drug development. And then in the earlier part of this century, these 3 drugs were developed. I will say that something new is that bedaquiline is now being recommended for children of all ages. And some important things to know are that bedaquiline is a substrate of CYP3A. That means there are significant drug interactions, so just be cautious about what you use it with. It causes moderate QT effects, so EKG monitoring is necessary. For delaminid, watch out for some central nervous system side effects. These are rare, but merit attention. And then for pertominid, there still remains limited safety information, but it makes sense to monitor liver function enzymes over the course of treatment. So this is the global new TB drug pipeline. You can see that there are multiple drugs in development. Many of these are from the same class, so you'll see these drugs in purple are cousin drugs to bedaquiline, and that the drugs you see in this sort of off-green color are DPRE1 inhibitors. Those drugs are of a completely new drug class. There are also some cousins of linazolid. You can see them here, delpazolid, sutazolid, OTB658. These are being developed to have the same type of efficacy that linazolid has, but with reduced side effects as we saw in the NICS-TB trial. So less peripheral neuropathy and less myelopathy or myelosuppression. So in summary, 3 new drugs have come to market in the last decade. We now have a 1-month treatment for latent TB, a 4-month treatment for drug-sensitive TB, and a 6-month treatment for XDR TB. We are really getting to a good place. Gradually, but we are getting there. There are many new drugs in the pipeline, including repurposed drugs, drugs of classes we know well, like linazolid, but redesigned to improve safety, and drugs of whole new classes. There is attention being paid to children and people with HIV, and I feel there is reason for hope. Who knows, one day we may even have long-acting injectables. I'm really grateful for the opportunity to be here and to interact with you and to be part of this conference. Thank you for the invitation, and my best to you all. Thank you.
Hello, my name is Yashwant Parathe, MDR-TB survivor, patient advocate, and peer counselor. I am engaged with SATB since last 2 years. Today, I have been invited on the panel Reimagining TB treatment in India, and I will be speaking on importance of treatment adherence tool and patient adherence tool and patient support tools. Now, हम देखते हैं कि क्यों पेशेंट सपोर्ट टूल जरूरी होते हैं। आज इंडिया में टीबी को एक गंभीर बीमारी के रूप में जाना जाता है, जिसमें बहुत सारे चैलेंजेस आते हैं, स्टिग्मा, मेंटल हेल्थ, काफी सारे एडीआर आते हैं, जिसमें पेशेंट को ट्रीटमेंट लेने बहुत ज्यादा मुश्किल होती है। पर ये चीज और भी ज्यादा चैलेंजिंग हो जाती है जब पेशेंट डीआर-टीबी का ट्रीटमेंट ले रहा हो, जिसमें एक मोटिवेट इंसान भी अपना ट्रीटमेंट सही से पूरा नहीं कर पाता। हेल्थ सिस्टम को एक क्लिनिकल अप्रोच से ज्यादा पर्सन सेंट्रिक अप्रोच लेना चाहिए, जिससे पेशेंट को और भी ज्यादा अच्छे से ट्रीटमेंट लेने में मदद हो सके। लेट्स लुक सम ऑफ द की एलिमेंट्स ऑफ द पेशेंट सपोर्ट टूल्स। पेशेंट सपोर्ट टूल्स इंफॉर्मेटिव होने चाहिए, इंगेजिंग होनी चाहिए, सिर्फ इंस्ट्रक्टिव नहीं होनी चाहिए। पेशेंट सपोर्ट टूल अगर इंस्पायरिंग हो तो और भी ज्यादा बेटर होते, या rather than blaming। पेशेंट सपोर्ट टूल्स एक पेशेंट के लिए बहुत ज्यादा रेलेवेंट होने चाहिए, और उसमें मेंटल हेल्थ सपोर्ट और स्टिग्मा मिटिगेशन के ऊपर भी डिफाइन किया जाना चाहिए। डजंट मैटर हमारे पास कितने भी अच्छे टेक्नोलॉजीज अवेलेबल हो, बट वो एक ह्यूमन कॉन्सेप्ट, ह्यूमन कनेक्ट रिप्लेस नहीं कर सकते। आज भी हमारे देश में एक गरीब इंसान के पास ये चैलेंज है कि वो अपना ट्रीटमेंट पब्लिक सेक्टर से ले या फिर प्राइवेट सेक्टर से ले। Now let's review of what's available for patient support tools. पेशेंट सपोर्ट ग्रुप्स बहुत ही ज्यादा पेशेंट को हेल्पफुल होते हैं। मैं एज अ टीबी सर्वाइवर बहुत सारे पेशेंट सपोर्ट ग्रुप्स में एंगेज हूँ, जिसमें पेशेंट को हमसे बात करके बहुत ज्यादा अच्छा लगता है। पेशेंट को उनके प्रॉब्लम्स का राइट सॉल्यूशन दे पाते हैं, पर ये ज्यादा मोस्ट ऑफ द रीजन्स में अवेलेबल नहीं है, सिर्फ लिमिटेड रीजन्स में अवेलेबल है, जिसमें सर्वाइवर लेड पेशेंट एजुकेशन वीडियोस बनाए है तो पेशेंट को ज्यादा और भी मदद हो सकती है। 24/7 टोल फ्री नंबर काउंसलिंग के लिए अवेलेबल है, पर वो सिर्फ मेडिकल पॉइंट ऑफ व्यू से ही आपकी काउंसलिंग करते हैं। पेशेंट ग्रीवेंस रिड्रेसल हेल्पलाइन भी अवेलेबल है, पर इसमें कई मेजोरिटी ऑफ द टाइम पेशेंट की कंप्लेंट को ठीक से एड्रेस नहीं किया जाता है। Now let's look at some key aspects which are still missing. आज सिस्टम में निक्षय पोषण योजना के दौरान हर माह पेशेंट को 500 रुपए तो मिलते हैं, पर वो इनफ नहीं होते। इसके अलावा और भी न्यूट्रिशनल और इकोनॉमिक सपोर्ट की बहुत ज्यादा जरूरत है। एक वर्कर को वर्क फ्रॉम होम फैसिलिटी के साथ साथ पेड लीव्स की बहुत ज्यादा जरूरत है, जिससे वो स्ट्रेस फ्री होकर अपना इलाज सही से पूरा कर सकते हैं। सेम चीज आप स्टूडेंट्स को भी स्टूडेंट लीव्स और फी रीपेमेंट फैसिलिटी की बहुत ज्यादा जरूरत है, जिससे फीस रीपेमेंट की वजह से जो रीपेमेंट मिली फीस एक स्टूडेंट को मिलते, उससे वो पैसे अपने इलाज लेने में खर्च कर सकता है। नाउ हम एक बार नजर दौड़ाएंगे कुछ ट्रीटमेंट अडरेंस टूल्स पे जो कि अवेलेबल है और कुछ चीजें जो अवेलेबल नहीं है। ट्रीटमेंट अडरेंस में पेशेंट को खुद ही अपना ट्रीटमेंट अडरेंस मार्क करना होता है, जैसे कि डायरी हो गया, एड्रेस मार्किंग चार्ट हो गया, और जिसमें आप पेशेंट खुद ही अपना एड्रेस मार्क कर सकते हैं। पर ये सिर्फ लिटरेट पेशेंट्स के लिए है। जो पेशेंट जिसको पढ़ना लिखना नहीं आता, उसके लिए स्टिल अपना एड्रेस मार्क करना एक चैलेंज है। हम मेडिसिन को मल्टीपल डोसेस में पेशेंट को स्प्लिट करके भी दे सकते, जिसमें एडीआर होने के चांसेस बहुत ज्यादा कम हो सकते हैं और पेशेंट का एड्रेस मार्किंग बहुत इंप्रूव हो सकता है। स्टिल इसमें फैमिली एंगेजमेंट और मेंटल हेल्थ सपोर्ट भी अभी मिसिंग है, जिसमें एक पेशेंट के साथ साथ उनके फैमिली मेंबर की काउंसलिंग होनी चाहिए, जिसके पेशेंट को एड्रेस पूरा करने में मदद हो सके और उसके मेंटल हेल्थ सपोर्ट भी उसे मिल सके। साथ ही में रिमाइंडर चार्ट, वॉइस मैसेज फैसिलिटी, वॉइस मैसेज रिमाइंडर, ऑन कॉल रिमाइंडर और ऐप नोटिफिकेशन के जरिए भी एड्रेस मार्क किया जा सकता है, जिसमें मिस कॉल एड्रेस मार्किंग फैसिलिटी भी अवेलेबल है। पर जो रीजन्स में नेटवर्क कनेक्टिविटी की प्रॉब्लम्स होती है, वहां पे ये फैसिलिटी उतनी ज्यादा इफेक्टिव नहीं प्रूव हो सकती है। साथ ही में एडीआर मैनेजमेंट टिप्स और ऑनगोइंग पेशेंट इंफॉर्मेशन और मोटिवेशन वीडियोस के द्वारा भी एड्रेस इंप्रूव हो सकता है। पेशेंट को सिर्फ ट्रीटमेंट की शुरुआत में ही नहीं, पर थ्रू आउट द ट्रीटमेंट अगर पेशेंट की रिपीटेड काउंसलिंग हो जाए, उसको इंफॉर्मेशन दी जाए कि उनको एडीआर कैसे करने, डाइट कौन सी लेनी है और सेल्फ मैनेजमेंट टिप्स, इसके बारे में अगर इंफॉर्मेशन दी जाए तो एड्रेंस इंप्रूव होने में मदद हो सकती है। नाउ हम टेक्नोलॉजी का भी यूज कर सकते हैं, जिसमें ई मेडिसिन बॉक्स भी अवेलेबल है। पर बहुत सारे पेशेंट जहाँ पे हम छोटे इलाकों में रहते हैं, जिनके घर बहुत ज्यादा छोटे होते हैं, वहां पे दिक्कत होती है कि उनको वो मेडिसिन बॉक्स रखने की जगह नहीं होती। तो ये एक सबसे बड़ा चैलेंज है। सर्वाइवर्स के एक्सपीरियंस शेयरिंग वीडियोस, जिसमें वो अपने सेल्फ मैनेजमेंट टिप्स शेयर कर सकते हैं, एजुकेशनल वीडियोस ऑन डाइट, मेंटल हेल्थ और स्टिग्मा, ये सारी शेयर कर सकते हैं। वो आज भी चीजें सिस्टम में मिसिंग है। अगर ये चीजें वीडियो फॉर्म द्वारा पेशेंट को दी जाए, तो उसमें डाइट, मेंटल हेल्थ सपोर्ट, इसमें पेशेंट को बहुत ज्यादा मदद मिल सकती है। Now let's go through some key learnings from my presentation. Number one, people and technology must go hand in hand. Number two, patient support for adherence is not one thing, it is many. Third is patient support is equal to adherence, but adherence support is not patient support. हालांकि पेशेंट एडरेंस ये एक पेशेंट सपोर्ट का हिस्सा है। पेशेंट सपोर्ट में बहुत सारी चीजें कवर होती है, मेंटल हेल्थ सपोर्ट, एडीआर मैनेजमेंट, डाइट से लेके हर एक चीज कवर होती है। बट एडरेंस में सिर्फ एडरेंस से रिलेटेड बात की जाती है, इसीलिए पेशेंट सपोर्ट इज इक्वल टू एडरेंस सपोर्ट इज नॉट पेशेंट सपोर्ट। टेक्नोलॉजी डज नॉट चेंज द इंडिविजुअल्स कॉन्टेक्ट। फोर्थ, patient information access will improve self management, and last but not the least, stigma, mental health, gender remain key address constraint. Thank you so much for inviting me to speak at InterTV Summit.
Hello, my name is Monan Kshal, and I'll be discussing how we can leverage novel tools to improve TB treatment adherence. It's first important to recognize that current recommendations and guidelines have now prioritized daily treatment 7 days a week for a minimum of 6 months. This long duration of TB treatment means that patient support is crucial for successful completion of therapy. Current guidelines therefore acknowledge the need for case management as well as health education and counseling that should be provided to all patients in order to optimize treatment adherence. When thinking about treatment adherence, I like to distinguish the concepts of treatment monitoring from treatment support. There are many reasons to monitor treatment, which includes documentation of adherence. There's no current biomarker for microbiological cure of tuberculosis. Successful treatment is therefore defined in part based on microbiological, radiographic, and clinical endpoints, but also based on the completion of treatment, which includes ingestion of a pre-specified number of treatment doses over a 6-month treatment duration. Real-time monitoring and documentation of adherence has the benefit of not only allowing clinicians to know how much treatment has been taken, but also allows the delivery of adherence interventions which might support individuals' treatment adherence. There are many different interventions that can be considered to improve patients' treatment adherence. These are quite difficult to study in traditional randomized or controlled trial format, and this is because the optimal interventions that achieve maximal benefit are likely to require tailoring to individual circumstances. The data for treatment adherence interventions is relatively mixed, but current guidelines acknowledge and support the usage of tracers, material support, digital medication monitoring, psychological support, as well as education as means of actually improving treatment adherence by overcoming various barriers that patients may be experiencing. It can sometimes be challenging to identify issues that are coming up related to treatment adherence. And that is where approaches to treatment monitoring can be used to allow for real-time determination of a patient's treatment adherence. Traditionally, we use directly observed therapy, often in the home or in the healthcare facility. But increasingly, new approaches that are more patient-centered have become available. Video observed therapy, for example, is now incorporated into current guidelines as a replacement for in-person DOT when it is available. Overall, the usage of observation is still preferred to self-administration, in part because it allows for real-time monitoring of treatment adherence and the ability to intervene with individualized treatment adherence interventions when adherence becomes worse. Here you see a schematic of video observed therapy, which typically includes a mobile smartphone component that allows patients to record themselves ingesting medications. The smartphone application, as shown here, can also have ancillary interventions such as daily reminders, as well as the ability to capture clinical symptoms and side effects, which can help the patient care team to support the patient in their treatment course. The different pieces of information collected by the mobile application are typically transmitted to a secure portal, which can be viewed by the healthcare professional. Video observed therapy can be implemented either in a live streaming format where patients are in direct communication during a live communication event with the healthcare provider, or asynchronously, in which case the patient records themselves, but then the healthcare worker observes and verifies treatment at a later date or time based on the recording. Several lines of evidence are now available that support the idea of electronic DOT or video-based therapy. In 2 randomized trials, electronic DOT was found to be very similar to in-person DOT in terms of being able to verify Monday to Friday treatment doses. In one study, video observed therapy was superior to in-person DOT. We have found similar circumstances in our local setting, and we have also conducted feasibility studies in a variety of settings, including in Pune, India. One of the benefits of video observed therapy with the advent of daily treatment is that it allows for monitoring 7 days a week. In a small pilot study in India, we found that we could document adherence for 86% of doses in 25 individuals when using video observed therapy. During the COVID era, we have found locally here in the United States that there has been an increased transition away from in-person DOT towards the usage of video observed therapy. Both before and after COVID, one of the transitions that we have noticed is that we are able to document adherence to a greater proportion of doses than was possible with in-person DOT, which typically was only Monday to Friday. By contrast, with video observed therapy, we are able to document treatment 7 days a week, and in some cases are able to verify adherence in more than 98% of doses. Overall, we have found that video observed therapy is more acceptable than in-person DOT, in part because video DOT is more private than in-person DOT and more flexible and takes into account patients' schedules and allows for treatment ingestion according to their own circumstances. When one cannot implement observation as a means of treatment monitoring, other less intensive forms of treatment monitoring are also possible using new digital health interventions. SMS or telephone call-based systems such as 99 Dots are now available, as are digital pillboxes, which can document each time the treatment is taken from the pill container. Also emerging are ingestible sensors, which allow for documentation of treatment after ingestion of medication, which has sensors that are built in. Overall, however, all of these are simply methods of monitoring treatment, and the act of monitoring is not inherently going to improve adherence. In sum, what I would like to suggest is that these new tools for treatment monitoring can and should be incorporated and connected to individualized plans for treatment support, which are now acknowledged and recommended in current guidelines. In-person DOT, video DOT, or digital medication monitors can be used to document treatment and identify situations in which adherence is falling to subpar levels. In such situations, individualized case management plans, which can include incentives and enablers, as well as other forms of support, should be considered to optimize treatment adherence. Thank you very much.
Hello everyone, I'm Devashri Lokhande, an XDR TB survivor and a fellow with ACTG India, and I'm here to conclude this panel on TB treatment, access and strategies, voices from researchers and the field, where we had excellent presentations from speakers all over the globe, covering this essential topic, which is a key issue to ensure equitable access to TB treatment and patient support. Dr. Monarch highlighted the need for patient-centered approaches for the management of TB, prioritizing of patient support tools to ensure treatment access, and the need for novel adherence tools to enhance treatment monitoring. Dr. Kelly throwing light upon the prevalent TB treatment pathways being followed globally and highlighting areas where an innovation and an overlay of supplementary patient support is required and how it can be ensured to make the patient experience more comfortable. We had Himanshu, an MDR-TB survivor and patient advocate from India, sharing his journey of overcoming TB, particularly how he was able to access treatment from the private sector in India. We also had Yashwant, an MDR-TB survivor and patient mentor from India, sharing his learnings from his own TB treatment and from stories of patients whom he has interacted with, revolving around the need for patient support tools, what these tools are, and adherence tools, which are presently being followed in the public sector treatment cascade in India. Thank you all for your valuable inputs to make this meaningful discussion, to highlight just how important it is to put patient support at the center of the TB treatment plan at every step, and how it directly and positively impacts TB treatment access and quality, helping us to defeat TB. Thank you. I hope I join you all at the live Q&A